so much for being here. My name is Antonia Apolinario-Caxton, and this year I serve as the president of the Minnesota Public Health Association. I think you are in for a great treat. Infants and toddlers are my favorite crowd, and I used to work for the Department of Human Services, and my first 3 years were working to develop programming. So I'm very grateful to these panel members, and I'm very curious to hear what is happening more currently. This is part of our new series, MYTHBUSTERS. What's tried and true? What's new? Today's topic is infants and young children. Today's moderator is our immediate past president, Saliares, and we're very happy to be working together. Thank you, Mary, our executive director. And Ellen is, she works as the Sexual and Reproductive Health Services Grant Manager at the Minnesota Department of Health. Previously, she worked in the field of sexual, reproductive, maternal, and child health as the Director of Maternal and Child Health at WellShare International, and the Director of Sexuality Education at the Annex Teen Clinic. Thanks again for your early presence here. Look forward to learning with these esteemed panel members, and I pass it on to Ellen.
I'll take my mask off. Who knows, if I mumble, you might not catch what I'm saying. Of course, not my ear. That's fine. Welcome, everyone. It is my pleasure to be here with you all and moderating this discussion about myth busting when it comes to infants and young children. As Antonia mentioned, my public health career is focused on sexual and reproductive health, relationships, sexual and gender identity, and reproductive justice. I'm excited about this discussion because it relates to my professional and volunteer work and a collective vision that I share in of communities where families are truly supported and cared for. I am also excited about this forum because I'm the parent of a 3.5-year-old. And you guessed it, that means he was born right at the start of the COVID-19 pandemic. So I spent a lot of time in my house, on the internet, on Instagram in the middle of the night, or texting my mother, and not a lot like out in the world absorbing and seeing how people are parenting. There's a lot out there. There's a lot of people putting forward their own books and their plans, and people, trying to remind us of decades-long advice. I tried to hold on to the advice that a nurse I worked with told me, which is to not let the Google monster steal your joy. But with the everything of 2020, 2021, plus being a new parent, it is very hard. There's a lot of pressure and guilt and worry, and recommendations change, right? How do you keep up with all of that? I'm an adult, and my mom still feels bad that I have a severe nut allergy because she is certain it's because she followed the recommendations at the time. And she's like, I'm so, when I was introducing things to my son, she's like, I am so sorry. I was doing what they told me to, and now you have this, serious allergy. I'm an adult, I've made it. I have EpiPens. There's a core tenet of It's That Easy, a program that I've done for many years that's about supporting parents and caregivers in their roles as sexuality educators for their children, that I personally hold and tell myself all the time. That is that parents and caregivers are doing the best they can with the information, resources, and support available to them. I think that's true for public health professionals too, right? Things change. We're doing the best we can with what we know and what is available to us in our time and our support in our community. The wonderful thing about this forum is that we're going to get more of all of those things, information, resources, and support, which will be helpful regardless of whether we're parenting, we've been parents, we're supporting families. And I'm really happy now to introduce our panelists. First, we have Linda Deck, who is the Executive Director for the Minnesota Milk Bank for Babies a nonprofit organization and an accredited member of the Human Milk Banking Association of North America. Prior to this position, Linda was the WIC Peer Breastfeeding Coordinator for the Minnesota Department of Health's WIC program. She has been involved with the Minnesota Breastfeeding Coalition since its inception, advocating for helping our current and next generation to have the best start in life by making it easier to access the best nutrition available. I'm a big fan of applause, so we're going to pause for applause for everyone. Next, we have Dr. Michelle Haggerty, who is a physician and board certified in family medicine, integrative medicine, and lactation. She is the founder and owner of Fourth Trimester Doc, a private practice that provides in-home care for mothers and birthing people and their newborns during the postpartum or fourth trimester period. She also provides consultations for lactation complications and perinatal mental health concerns. She has extensive training in yoga, mind-body medicine, nutrition, Reiki, osteopathic manipulative therapy, and integrative perinatal psychiatric care. She also has an interest in public health and a master's in public health and nutrition. Applause! All right. And finally, we have Jenny Lippert, who serves as the Family Home Visiting Section Manager with the Minnesota Department of Health. This work supports the integration of family home visiting into the state's comprehensive early childhood system. The MDH Family Home Visiting Team understands the importance of relationship building with a variety of partners to increase capacity for communities, to promote the healthy development of children, secure attachments between caregivers and children, increase self-sufficiency and safety of families with infants, and improve pregnancy outcomes. Prior to joining MDH, Jenny was the Health and Human Services Director for Candy, Ojai County. In this role, she directed the operations of 161 staff. Applause in itself, I feel like.
During a pandemic.
That's true, that wasn't in my notes. Which had a number of service delivery areas, including income maintenance, accounting, child support, mental health, substance use disorders, child protection, welfare, and home and community-based services. Let's have some applause for Jenny. All right. So if you're not familiar with the structure of the forum, we're going to have our panelists do some opening remarks. Then I have some questions to get us started. We'll pause for table discussion and for you all to come up with any questions that you have. We'll come back together and we'll just answer whatever comes up. You look ready. All right. We're going to start with you, Linda.
Morning.
Let's see. Can you hear now?
Yeah.
Good morning, everyone. Thank you for inviting me here. I'm glad to see that it's fall. Now it's fall. I can see now the lights up. The risen looks very nice outside. So glad to be here. As was mentioned, I'm director of the Human Milk, the only milk bank in Minnesota. Minnesota Milk Bank for Babies is a nonprofit. We got going in about 2019 when we were accredited and licensed by the Minnesota Department of Agriculture and accredited by the Human Milk Banking Association of North America. At that point, it took about 6 years or so for the founders initially to get the milk bank up and running and raise enough funds to build out a site, to lease the space, to hire staff, get us trained, accredited, and licensed. We collect extra milk that moms have beyond what their own babies need. We screen the donors, we test them for diseases, and it's very similar to the process of donating blood. After that, if they are approved to donate, then they make arrangements to drop off their milk at what we call depots or milk collection sites around the state. We have 29 of them currently in Minnesota and one in North Dakota, one in South Dakota. And we're slowly adding more. Once we get the milk to the milk bank, we process it by pasteurizing it. And for those who are familiar with pasteurization, you increase the temperature to 62.5 degrees Celsius, and hold it, and then cool it down rapidly. And that's to get rid of any of the bacteria or viruses that may exist in the milk, because after that, we test it again for any growth, and if it passes, then we can dispense it to hospitals and to outpatients. Most of our milk goes to inpatient hospital units. We serve 33 different hospital and maternity centers in Minnesota. With that, it goes to NICUs, special care nurseries, and other inpatient units. About 2/3 or 3/4 of our milk goes to inpatients, and about 1/4 of our milk goes to outpatients. So it's meant to be used as a bridge. We are there to provide mom's own milk has always been considered the best nutrition for babies. And when that's not available or in short supply, then pasteurized donor milk is the next best option because of the anti-infective properties in it and the other wonderful things that make human milk the best source. So we've been going now for almost 5 years, and we're getting ready to move into a new location, a larger location that will allow us to increase our production capacity. And we're looking at also ways to increase access to our donor milk. It gets, as you can imagine, expensive, $4.75 an ounce. It is something that is kind of cost prohibitive for many, and we are looking for ways to increase access to that. And we have some pilot programs going to do that through food pantries and through the Division of Indian Work, and now through public health, through the family home visiting programs that we would like to expand. So that's just a little bit about our program here. I'm happy to answer any questions that you have.
Thank you.
Hi, I'm Michelle Hagerty. As just mentioned, I'm a family physician, and I started a home visiting private practice called Fourth Trimester Doc. For those who aren't familiar, fourth trimester is considered like the postpartum period. So we've got the first, second, and third trimester during the pregnancy, and then the fourth trimester is those first 3 months and beyond postpartum. It's really the birth of this practice was started after I had my own children. I've got 3 kids under 6 and have also 2 angel babies. So I've had 5 pregnancies in the last 6 years, and it's after the birth of my son, my oldest, I very quickly realized how focused on the newborn and the infant, which we're focusing on today, but that really the whole medical world is really interested in, and the mother or the birthing person just sort of falls by the wayside. It's like I was a vessel that just had, birthed this baby, and then everyone cared about my health all the way up until the baby was born, and then all of a sudden, you don't matter anymore, right? And I, as a family physician, was seeing folks in the clinic and having these families bring their babies in and doing the weight checks and checking the bilirubin and all of that. And I was seeing these parents bringing the newborns in, and these poor birthing, the mothers, the birthing people that were coming in there. You're leaking from every orifice, let's be clear, right? Everything is, for me, I was still personally wearing diapers for 2 weeks postpartum. There's a lot of stuff happening, and just went through this major life transition and this frankly very physical trauma to my body. And even though I had very straightforward births, it's still a very traumatic experience. And so I should have been at home healing, and I should have been in my bed and allowing my body to heal. I have a wound the size of a placenta, which is like the size of a dinner plate on the inside of my body that I'm bleeding from. And and this is, and yet we're, if this was on the outside of our bodies, we would never tell anybody to go around carrying a car seat and doing all these things. But the newborn's health is important, so we really focused on that. And so I realized I was doing such a disservice to my patients and wanted to change. Looked into what practices that were doing across the United States, and there was really nothing happening. There was a home visiting nursing program and things, but there was, when we're talking about the medical side with seeing physicians, everything was happening in the clinic setting. And so I sort of was like, there's got to be a way. And I got fellowship trained in integrative medicine, and that is a little bit of an alternative, or it focuses on alternative or complementary practices. And through their models thought, well, I can build up my own dream practice. I can do this. And so I did. I 3 years ago, COVID, is when, after the birth of my second child, I birthed this practice into being. So started very part-time, and was still working at a clinic, and then was seeing folks postpartum. I would do a prenatal assessment where I would go in the home and we would do postpartum planning. So people really plan for the birth, but then they don't plan for postpartum. There's always like, what medications are you gonna use? Are you gonna, are you gonna do skin to skin? All these things right away after the birth with the baby, but then what happens after that? One of my favorite doulas talks about if you're planning for the birth and not postpartum is like planning for a wedding and not the marriage, right? Like you need to plan for what's going to happen afterwards. So it's a really important time. So so that's the start of my practice. All of my patients I see in the home, and we do a postpartum planning session in the home for about an hour and a half. We go through their cupboards, we go through their bedroom, we go through their bathrooms, we make sure we set up everything so that they are set up for success when they come back into the home. And we talk about nutrition, we talk about relationships, we talk about exercise and movement, we talk about mental health, all the things to sort of prep them for the postpartum time. And then postpartum, I start seeing folks, actually I'll go into the hospital and see them in the hospital, and then also within 24 to 48 hours after they're home. So a lot of times the home visiting nurse will be there, one day, and then I'll be there the next day. And so we're really, the standard model in the medical system right now is that the birthing people aren't seen until 6 weeks postpartum. I usually see people 5 times within that period. I'm catching postpartum preeclampsia. I just sent somebody in the hospital yesterday actually with concerns of a possible stroke. There's all kinds of things that happen, and we know the maternal mortality rate is really high in this country, and this is why we're not seeing families quickly enough. So, there's data that supports that 80% of the maternal deaths postpartum are preventable. 80%. That is insane. I'm sorry, that is unacceptable, and there's a reason why we're just doing huge disservice to our families. So that's my practice, and I love it. I have now transitioned out of the clinic, and I'm doing this full time. I've hired another physician, and there's 2 more that will be coming on board in the next couple years here. So, and we're really focused on all the aspects, everything from the lactation to the perinatal mental health to physical, the pelvic floor, all the things. Infant health, we do all the weight checks and bilirubin checks and stuff in the home as well. So there's really no reason to go into the clinic unless there's an emergency, and then you're going to the ER. So no clinic visits there. So that's me and my practice. Thank you.
Good morning, everyone. Jenny Lippert again with Minnesota Department of Health Family Home Visiting Program. You heard a little bit in the bio about the home visiting program, but our team at MDH offers consultation, technical assistance, professional development. We do data and research. We do continuous quality improvement and grants management for local public health, tribal health departments, and also nonprofits throughout the state of Minnesota who are doing the home visiting to serve the families. We at MDH administer roughly $40 million in state and federal home visiting funds to 71 grantees across Minnesota. We serve and support 84 of the 87 counties. Local public health is doing home visiting throughout those counties. And of those funds that we administer locally, 65% of them are designated to do specific evidence-based home visiting programs and work with those curriculums. And I, like Dr. Michelle, am a mother myself of 2 young children, and I even go back and look at the curriculum that these nurses are providing to the families because it's such a wonderful support and just provides additional resources to really engage and grow a family dynamic. We know that family home visiting is often one of the first doors that opens a family to additional services and resources that might be needed to really improve the safety, health, and well-being, not only of the mother or the caregiver, but of the infants and children to really create a healthy environment for all of our kids within Minnesota. So I won't take any more time. Let's get to the questions that you all have for us. Thank you.
Thank you.
Since whoever can answer this question, because I want you all to answer it, could you identify and speak to a piece of advice that has changed in the past 20 years? And about like how people can access different services related to like the type or whether or not they have insurance. So if each of you maybe could talk about things like how is baked milk, like how is that expense covered in hospitals? How is it covered if someone goes home? How are postpartum visits being reimbursed? Just issues of access in general. That would be wonderful.
Issues related to access for pasteurized donor milk is there is something on our forefront, on our brains, just because in Minnesota, pasteurized donor milk is not reimbursed by medical assistance or by insurance at this point. 14 states and the District of Columbia do have reimbursement, and we are approaching, we have approached, our medical directors have approached DHS to have this discussion. So it's in process now to at least cover inpatient and outpatient to certain time periods for medical conditions related to either mother or baby. Because at this point it is not reimbursed. Yes, that does affect access, obviously. So it's something, a topic that we're working on. DHS has been listening and agrees that it's something that we need to address, particularly inpatient. Yeah, the babies in the NICU, they'll sometimes cover, the hospital basically covers the cost as part of their quote hospital bundle. And as you know, anything that's not more specific in the hospital bundle, it just sometimes doesn't get covered. Sometimes they pass it along to the families, but most of the time the hospitals absorb the costs, which makes it, limits its access as a result. So it is something that we are discussing with DHS in terms of coverage, hoping that 15th state and have this be more equitable. And given that it covers about 30 to 40% of births in Minnesota, once MA begins to cover it, the insurance companies will begin to follow. So, work in progress.
Yeah, so insurance is sort of a thorn in my side. It's yeah, you're right. So unfortunately, what has happened in the standard medical system and across the country is that insurance reimbursement back to clinics has not increased and has in fact decreased for even though like our the cost of living has increased across the country. And so clinics are having more and more trouble being able to continue to provide support for folks and continue to take insurance, which is why we want these 10-minute visits and these 5-minute visits and these really, and you're not able to get a hold of your physician or your healthcare provider because they are working their butts off trying to see as many people as they possibly can in this short period of time in order to get enough money into the clinic system to be able to continue to sustain the practice. As a private practice, it was completely cost prohibitive for me to be able to take insurance and directly contract with insurance companies. They do things like take money back from clinics. They don't reimburse percentage of clinics visits that you see just for the sake of they just deny claims just because they want to. They down code, so even though you may be seeing for somebody for a certain level of care, they decide, oh no, that actually was less than that, even though they have no idea, they weren't in the room, they have no idea what's going on. So there's a lot of like not great stuff happening on the insurance side. And for me, I chose to not go this route because I wanted to be able to provide care on my terms to people, and meet them where they're at. And so I want to be able to provide home visits. I want to be able to provide, 90 minutes to 2 hours, in the home and not have somebody else dictate what I'm doing, and whether or not I can actually continue to do the practice. That being said, I am considered out of network, meaning that I don't contract directly with insurance companies. What I do though is that people have out of network benefits, especially if they've got PPO plans, and it works actually fairly well because all of my visits are considered preventative care. So a lot of those are either fully covered or very highly covered, even in the out of network realm. So people don't have cost sharing necessarily with those visits. And so I provide either a super bill or submit claims for patients. And so they will pay me up front, and then they will get reimbursed from their insurance company for my care. So that means that I get paid the amount that I should be paid. I know that the money is coming in, and also then patients are the ones that are contracted with their insurance companies, so they get to talk through that with insurance companies and get those reimbursements. And it usually works out fairly well. The other side, so unfortunately with that, I can't take medical assistance or Medicaid because that sort of model doesn't work with that. But I am able to see, so I provide, because of that, I then can provide care at a steeply discounted rate for those folks. I can do sliding scale, or I can do pro bono, or I can do whatever kind of works for people. And again, because I get to dictate the care. So it's really lovely because then I am able to support people just sort of along the spectrum. I have been looking into grant funding and trying to figure out if there's other ways that I can provide more comprehensive support now that I'm sort of stabilized in my practice. And so down the road, I think that there's going to be more of that that's going to be happening. But yeah, I'm proud to say I'm actually out of network because I think it really speaks to the care that I provide and allows that connection to happen.
So insurance is a sticky, hard to navigate system for all of us. Now I think about being a recent immigrant to Minnesota and how to navigate that system. So I think you have to go back to the basics in terms of how do we reduce the stigma and provide information to everyone throughout the state around benefits that includes private insurance, but also Medicaid and medical assistance. The unique part about the family home visiting program is that it essentially is free because of the state and federal dollars that we receive, and we give that down to local counties or implementing agencies. Anyone throughout the state of Minnesota can receive home visiting services. The other really nice thing that I think this state offers is a lot of local and state support for these services. So a lot of counties throughout Minnesota are supplementing the state or federal funds that they receive from MDH and also adding local levy dollars into their braided funding approach. And I think that that speaks to just the real relationship and the positive measures of having that trusted individual that walks alongside you. Again, I would put a caveat into being culturally sensitive and appropriate. We're seeing a lot of counties throughout Minnesota that are hiring and doing a lot of training to support those folks that can't navigate the system, nor can they advocate for themselves as a new mom, someone who just gave birth, who's so focused on their child and not about their own mental health or health of themselves in general.
Well, and I have to run off to a funeral in a few minutes, but I can't help but ask now, in a more sane world, why couldn't Jean, you be supplementing Michelle's work? Okay, I'm asking, why couldn't the state, through the Medicaid program, be helping Michelle with this wonderful service that she's providing?
We're going to talk about that. There is some side discussion happening. Yeah, so that, I mean, honestly, that is where, I have sort of, my vision is that what I wanted to do was stabilize my practice and make sure that I had a good, solid practice first, and then be able to then reach out to figure out ways that we could, find government funding, or I actually tried to do it. I tried to create a side nonprofit that try to get grants through the nonprofit, because I'm a for-profit company. But I created oh, there it goes. I created a nonprofit, but then I would get grants to then supplement what I was doing. And it's like there's all of these hoops and jumps and all, you know, these things you have to go through to kind of get there. But it's gonna I'll put it out there. It's gonna happen. I'm gonna make it happen. It's just it's gonna take some time, I think, and an effort to do that. I will add with one additional thing that's sort of an interesting parts of this insurance aspect too, is that lactation care is required by the ACA to be covered by insurance companies. Insurance companies have decided that they're going to avoid this by not credentialing with lactation consultants, the International Board Certified Lactation Consultants, or IBCLCs, because they're not licensed. They don't get a license. That's not something that happens for them. They get certified, they have a certification, they get board certified, but they don't have a licensing board or anything like that. So insurance companies have decided, well, we're not going to credential with lactation consultants because they're not licensed. So they, this is how they get around not providing lactation care in network for people. So this is the fun of insurance companies, right? So I got really excited because I was like, well, okay, so I'm an IBCLC, I'm a lactation consultant, but I'm also a physician, which means I'm licensed. What does that mean? That you have to provide my care as an in-network service, even though I'm not credentialed with you, because you are required by the ACA to do so. So patients can actually contact their insurance company and ask for something called a gap exemption, meaning that the insurance company doesn't provide this care they don't have anybody licensed that's credentialed with them. So now they have to provide it as an out-of-network service with me. So you play the game, you can make it happen. And I don't have to do all the paperwork and all the things and all the whatever to try to get the insurance companies to cover my services that way. So for lactation specifically, they get it covered as a service.
So I was part of the Minnesota Breastfeeding Coalition, and I still am part of the coalition. And several years ago, we tried to move past licensure for IBCLCs, and I am one. It took 4 years; it did not work. Did not pass. And we kind of ran out of steam and funds because it's cost my entire lobby. So yeah, it's frustrating because it's from physician IBCLCs that are there.
Same as I think it's classified.
Whereas IBCLCs are, there's more, and yes, it's not perfect. However, yeah, finding a way to get the insurance.
Thank you. All right. Jenny, there's a question about how evidence-based programs are adapted to cultural communities and how often. And as I'm going to be culturally specific, family home visiting program funded by MBH that we culturally adapted. I feel like you probably could answer that.
Sure. So there is an official site called POMV, and that's where any model would go through testing, and whoever is developing the model and has done the research on it. I think it's on again. A model has to go through years of trial and testing in order for it to then meet the credentials of the POMV accreditation period. So for instance, Minnesota. So about 4 years ago, Minnesota was the first state within the United States to trial or pilot the MESH model. That's a model out of Western Sydney University. Dr. Lynn Kemp and some of her fellow colleagues there have utilized this model in Sydney, Australia, United Kingdom. It's been in Seoul, Korea, and then now most recently in the United States. And so we have gone, this will be our 4th year. We're just starting in January. So we have been working on doing data collection and providing that back to Western Sydney University. And then now this model is evidence-based and will be on the POMV site. So it takes a number of years. It kind of just depends on the research and the curriculum. The home visiting models have different curriculum and different ages that they can work with families. Some, they only can work prenatally up until the child is 3. Most recently, we're seeing models that do some type of adaptation because they're seeing the need to serve children longer up until the age 5 or 6. Before then, we can do a soft handoff to some type of ECFE or early childhood program.
Thank you. Does anyone else have other thoughts or things to share about how evidence-based programs can be adapted for specific cultural communities? Okay. Another question we have is, how do you involve fathers or non-birthing people in your services? Whoever wants to take it.
Yeah, this is a personal passion project of mine as well. I involve them a ton. My prenatal postpartum planning session includes the partner, and I also do a separate phone call with the partner that does not include the birthing person. Just talking with them about what's this change look like for them, and what are they planning, and what are some challenges that they see that may be coming in. For example, I had somebody that had chronic migraines, and he didn't sleep enough that he would get a migraine. He was like, how am I going to be able to support my new baby and my partner with, if I need sleep. And so we talked through sort of what does that look like. Postpartum paternal, the depression in the partner is very real and starts typically around 6 months postpartum. A lot of people are not screened for that. So we talk a lot about how to resources and connecting back with me, or connecting back with who maybe they have a therapist, or just really sort of making sure that they're being assessed and so they have resources that they need to then go back and get that support if they need it. And then the final thing is that birth trauma both happens for both the birthing person and the partner as well. And I don't know that I really understood the extent of that until speaking with people. In the first visit, we do a sort of a narrative medicine experience where they tell me their whole birth story, that everything that happened from start of the birthing times all the way through the end, and all the little things that occur, in there. And I find it's really fascinating to have the birthing person and the partner tell the story together, because they kind of fill in the gaps for each other. For example, if the birthing person needed to have a C-section and they weren't able to see or hear the baby when they first came out, and they didn't hear any cries, and so they had this sort of 30 seconds of panic that sort of ensued. But the partner was there, and they saw the baby, and they saw the eyes were open, and they were alert, and they were just kind of looking around, and they looked perfectly fine, but they just hadn't cried yet. And so filling in that gap for that birthing person, the trauma goes away, it melts away, because now they're not panicking in the middle of the night, thinking over and over again that the baby didn't have oxygen for that amount of time, or that baby didn't have, something was happening to that baby during those first moments, when it was just a beautiful birth, and they just, everything was all good. The other side of it is that, I've seen, the birthing person is going through their transition, meaning that they're sort of about to push, and their whole body is just in their animal mode. They're just they're roaring and they're screaming, and they're just oh my God, all this stuff is happening. And the partner is looking at them thinking that they're dying. They legit think that they're just they're gonna keel over, and this is the end for both of them, for both the mother and the baby. And so you talk about, as you're going through the birth story, the birthing person is no, this is one of the most powerful moments of my life. I was in my element. I was ready to birth this baby. This was a beautiful time for me. I was not going to die. Everything was good. And so the partners, I'm oh, thank goodness, things are okay, good. I'm feeling much better now. And they're not panicking about it for forever and long term. So I really think that that's including the partner in this whole experience, which is really, really important. And so they're not, it's not just the birthing person and the baby that are sort of had this transformation. It's this whole family unit, and we really need to be supporting them as they're in a transition together.
I have to say that over the years, I think this is where we've seen a lot of wonderful change. That dads or partners are far more involved, and it's truly great that they want to help. Because at the milk bank, actually, probably talk to more dads, partners than I do the moms themselves, because they're the ones kind of helping the mom, with okay, there's some issues going on. I'm gonna go find out about the milk, they've been deferred to us. It's a process. And they're truly wanting to help. They ask the most wonderful questions. They truly really want the best for their baby, and want to play a significant role in that. So it's great to see it. If they ask different questions than moms, tend to ask, and you meet them where they're at, and sometimes they're more concerned about actual temperatures of the milk and actually measure them, and things. So it's a wonderful thing to be able to have these conversations with partners who want to be involved and want to help. I think we work with a lot of grandparents as well. It's great to see when the families and friends kind of gather around, that people come, siblings, partners, sisters, and aunts, uncles, grandparents come and pick up the milk and ask for the instructions and how do we do this so we can help out. So that's been really great, and I really think it makes a difference. What Dr. Harry was talking about, what happens afterwards, or when a mom just needs to take a break or lay down and feel that the baby is safe. Those are they're small things, but they mean a lot to begin. So it's great to see that parents are starting to realize that it's okay to ask for help. And this is the kind of help, the good help that is needed. So it's a really refreshing to see how that's evolved.
And I would agree, in home visiting, we are seeing more dads being involved in the education of what we're going through with the mom. And part of that is maybe the nature of not intact family dynamic. So if, for instance, the mom and dad do not live or reside in the same household, we want to make sure that then when that baby does go to stay with the father for a week or whatever their plan time is, that he has the same information that we're giving the mom to, again, ensure that this child is safe and has all the tools and resources to be successful. We also, was mentioned before, are seeing bigger family units. So sometimes we'll educate the mom, but the mom will tell us that, well, I live at home with my parents and my parents don't want me to do X, Y, Z, or they won't allow me to put safety clips on the cupboards because my mom doesn't want that in her house. And so then we need to go beyond that and have that conversation with that grandparent or aunt or whoever that individual friend, whoever that person is living with. So we are seeing more people involved in a child's life than just the mom or the dad of that child.
Thank you. We're getting to the end of our time, but I'm going to ask you each to share and say one sentence on what you think would be like the biggest, just game-changing thing for infants and young children that you want to see happen. What could have the biggest impact? I know this could be like introducing entirely topics we haven't got to, so sorry, but what is it? What could really improve health for infants and young children?
What I talk to families the most about, and what I think I always try to come back to is trusting themselves and trusting their infants. So I want them to be able to really hone into their intuition and figure out what does parenting look like for them. There are a million different recommendations out there with sleep and feeding and preschools and all the things, and you can just go down any sort of realm with any of that, and it's and I just think that if people can sort of be able to take advice or read whatever it is and say, like, does this resonate with me? Does this feel good for me and my family? If it does, great, let's try it out. If it doesn't, thank you, moving on, and then try to figure out whatever works for them. So coming back to their intuition, I think will be just crucial to really finding that home.
I would say getting to a space where everyone views walking alongside that individual, that parent, that family, not talking down to them just because you are a professional, whether you're a professional nurse or you're a professional physician. I don't believe that we should be going into meeting with these families as though we know more and we're telling them what to do. So kind of parallel to what Dr. Hagerty said, I really think we need to invest in education and resources all the way from culturally sensitive information just to how you really build that true relationship with that individual, that they are going to you when they've got a question and not going around the system. So again, walking alongside our families to support them.
I think to get infants and families off to the best start possible, paid parental leave that leads into transitions into high quality, affordable, accessible childcare is going to make a huge difference in terms of families being able to be the best parents that they want.
Thank you so much. Those were things I think that both suggest, like programmatic policy things that we all could advocate for, but also just how we're relating to each other. Like, how are we dealing when we see a struggling, parent at a grocery store? Like, how are we responding if we're trying to like push the thing that like my grandma said you have to do with your kid on someone else? Like, how are we also being in community with each other and recognizing that we all have a role in supporting everybody, families that are similar to us, families that aren't? Like, how are we all helping each other grow? Because there's not enough support out there, so we all have to chip in, my opinion. I want to thank you all so much. I'm going to pass it back to Antonia for our closing. Let's get some applause though.
Thanks, everyone. And I'd invite you for another round of applause because the information is so relevant and it's so needed that all of us need to have this information so that when we see a struggling parent at the supermarket, we can be supportive rather than to take care of this kid instead. So. Thanks again for coming this early morning. Our next forum is January 19th, next year, and the topic is children and adolescents. So we're going to go up a little bit the age. There are other upcoming Minnesota public health events, and I don't know, Mary, if you'd like to state them, but we are going to have continue to have the policy forum. We are going to have also race and health equity gathering, and we don't have a date yet for that. You're invited to join the association if you're not already a member. We need paying members to make our association stronger. And if you like Starbucks, I have 2 gift cards that we would like to give it to you in a way that, so today is the 27th of October. Thank you, Ellen. Yeah, for young minds. Whose birthday is closest to today's date? November 5th. Anybody closer? All right, you're the winner. Elsie, congratulations. And we have another one. Who comes next?
I'm September 17th. So my year, September 29th. Oh, September 29th.
All right. Congratulations, Bonnie. Is that it?
Yeah.
Thanks again. And again, I'm Antonio Wilcoxon, Mary, Ellen, and Emily. Thank you very much for all your help, and thank you so very much for coming and give us this important information. Thank you.